record. Victoria, if you can hear me, we are ready to Facebook stream live. I'm sending you a text right now. So as you guys have already kind of figured out in the last couple webinars, we have been streaming live to Facebook. This is just another way for you to view the content, especially if like you don't need the CE, maybe you're in a leadership position and you're late at the office and you want to, tune in, but you don't really want to invest all of the time in the CE itself. This is a great way to watch. So you can catch us live on Facebook on our Facebook page. Next month, we are going to be doing our last webinar of the year, and it's part 2 of OB emergencies with maternal 911. So they were just exceptional. So I highly recommend, even if you didn't come to part 1, it doesn't matter. We're going to cover new material in part 2. So that's going to be a great webinar. And then I am still working on the schedule for 2021. I am going to be posting that soon. We will definitely keep the webinars going. And we're also going to be adding some really cool things into the mix. We do have a project up and running with Michigan State University for virtual simulated distance learning. So more about that will come your way. So keep your ears and eyes open. So now I'm just going to go ahead and introduce Kristine Kuhl. She is
how cool that looks.
Please be sure you are on mute.
And then this is my coffee. So I figured I'd put this up here.
Get another one of those so we don't need countertops.
Happens every time.
Hey,
Yes and
Victoria,
no.
are you on the other end there? I don't see you.
So, I mean, it's nice, but
I'm
I think
here.
it could be with regular counters.
I can't pinpoint that sound. Okay, it went away. Cool. So sorry, Chrissy. So
That's
I'm
okay.
going to introduce Kristine Kuhl. She is the Community Integrated Paramedicine Coordinator with the Bureau of Trauma and the Bureau of EMS Trauma and Preparedness through Michigan Department of Health and Human Services. She's also an esteemed colleague and paramedic and all of the other things that I probably am not doing justice. So feel free to make your own introduction. But welcome. I'm going to turn the floor over to you, and thanks everybody for attending.
Hi, everybody. Thanks for allowing me to come speak to you today. So I don't seem to have control right now, Andrea. Can you hear me?
Oh, sorry, I was on mute. Let me take a peek here and see where you're at.
Escarino can hear you.
You don't show as a non-host on my end. Hey, Victoria, are you able to look at Kristine as well and make sure?
I can do it now. I have control.
Okay.
Now. Thank you. Okay.
Good deal.
Well, hello, everyone. As Andrea said, my name is Kristine Kuhl. I go by Chrissy. It doesn't matter. Whatever. And we're going to talk about community integrated paramedicine today. What we're going to start with, though, is a little poll question. I like to call it fact or fiction. We're going to see how much you know about community paramedicine and EMS in general. And I like to call it, we're going to dispel some myths, I think. And the reason that I do this in the beginning is there are some certain premises that we don't all know as truths when it comes to how EMS systems work. And it's pretty important because the rest of it builds off from that. These are objectives. We're gonna, by the end of this, I want you to be able to argue for and against community integrated paramedicine. All right, fact or fiction? And Andrea has some polls for you. In Michigan, a paramedic license allows you to work in a variety of places, such as a hospital or an urgent care. Fact or fiction? And the second question is, EMS is part of public health, fact or fiction? So go ahead and show me your answers.
All right, sorry about that. I launched
That's
a little early. So keep in mind when you answer these polls are anonymous, so I can't track like who or what. I know some people worry about being honest, but this is not trackable in here, but we can share the results. So here we go. So this should show up on your screen on your end. You're going to pick fact or fiction for each question. We'll give you about 30 seconds or so, and then we'll wrap up the poll and you'll actually get to see the results from everybody in the group in an anonymous
I
fashion.
love doing these polls.
I do too. It's a good engagement tool too. So you're not just sitting on the other end, you actually get to participate. So I think this is a great function. So if you're sitting on the other end, be sure you answer this poll. Well, it looks like we have almost everybody actually. We're missing maybe 8, 7 people. If you're eating a turkey sandwich and you walked away, put it down and come back.
Yeah, I'm good.
All right. Got 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. All right, we're going to end polling. And here are the results.
All right.
Are those showing trend?
So
Yes.
I could say 87% of you believe the first one is fact, and 77% of you believe number 2 is fact. Okay, so I'm gonna move this, and
Okay to stop sharing?
yep, it's okay to stop sharing.
Okay.
So a paramedic license allows you to work in a variety of places such as hospitals or urgent cares. And notice I said Michigan. Oh, I don't have control again. Fiction, actually. That might be surprising to a lot of you. So here's the thing, your paramedic license, you're licensed through the state EMS office, not through Laura. Laura handles, I mean, you can still check your licensure on Laura. But to fall under Public Act 368 and for the EMS office to have purview over what's happening, you have to be a licensed person working for a licensed agency under approved protocols that the state has approved. So this is one of those things. Your paramedic license may be a vetting tool for someone to hire you. They may require that you have a Michigan paramedic license to work in the, let's say, the ED. But if you're in that ED, you have no EMS protocols that you're running under. You're running under the hospital. If you kill someone in that ED and they were to come to the EMS office, we have nothing to do with it. You are not working under your license. So we have no more control than if they said that you had to have blonde hair to get that job. It is completely irrelevant to us. So EMS is a part of public health. That is true. Fact. And in fact, a little government history here. There are like 17 departments in the state of Michigan. Michigan Department of Health and Human Services being just one of those. Inside of that, there's several agencies. Public health is one of them with Dr. Joni Caldoun that you see on all of the conferences or all the governor, what's the word? The governor, when she does her little, not webinars, for press conferences. Within public health, then there are several bureaus, and the Bureau of EMS Trauma Preparedness is us. And then within that, there's 3 divisions, and the EMS and trauma houses both EMS and trauma. All right, one more for polling questions. Only an EMS agency can be approved as a community paramedicine program in Michigan, so not a hospital or not a health system, and it is expensive to start a community paramedicine program. Go ahead.
All right, launching poll. Here we go. So fact or fiction, you've got 30 seconds to answer. Go ahead and select what you think is best. All right, you got about 10 more seconds. Looks like we've just got a few people left. All right, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, ending poll.
All
Show
right.
results.
Only an EMS agency can be approved. The majority of you believe that. And it costs a lot. The majority of you do not, you think that that's fiction. So you can go ahead and stop sharing that, Andrea. Only an EMS agency can have a community paramedic program in the state of Michigan. So we're going to talk in a little bit about mobile integrated health versus community paramedicine. But because when I told you that your license doesn't, you're not really working under your license when you're working in ER, you also shouldn't be called a medic when you're working in the ER. There's part of the statute, Public Act 368, that discusses using the terminology that is related to your profession and the purview of the state office. So when you're in the ED, you should be called something else besides a medic. Community paramedicine programs, the word paramedicine puts it under the umbrella of EMS. Next question, it is expensive to start a community paramedicine program, fact or fiction? And that is fiction. So it can cost, if you would like all bells and whistles and you would like to do everything underneath the sun, but the human being is the biggest part of the community paramedicine. A trauma program, obviously, you have to have a person with knowledge, but you also have to have lots of toys to do a trauma program. Community paramedicine is really about an individual with problem-solving skills and patience. So I get asked a lot, why are we putting so much effort into this? Other states have done it pretty well. There's all these programs that people read about. Why reinvent the wheel? Why don't we just do what they have been doing? Copy that and replicate it here. Well, the answer is it's a different regulatory structure in Michigan than it is in many states. So I would be really happy to not reinvent the wheel. I took their wheels, but this is what it ends up looking like. They're square wheels on our bike. It doesn't work in Michigan. So the biggest difference that I noticed from, I have attended a lot of national conferences, is the EMS medical director. They have one per agency in a lot of places, not every single state, but a lot of states. And some of them do have MCAs, but their EMS agency medical director plays a different and a bigger role than they do here in Michigan. So though the agencies that are CAS accredited, a lot of those will have their own medical director for the agency, but they don't hold the same level of authority as our MCA medical director. So in Michigan, our office is about 20 people. There are over 800 agencies of all levels. We have about 29,000 personnel, 4,500 to 5,000 vehicles, 87 counties. Almost every county is an MCA, but there are several MCAs that include more than one county. So we have 63 medical control authority physicians. That's 63 physicians to 800 agencies and 29,000 personnel. So you can see the difference. If you had one dedicated EMS director, or what we would consider an MCA physician for every agency, I mean, we'd have, what do we have? We'd have over 800 of them in the state of Michigan, but they would have a more intimate knowledge and be able to get things up and running in a different way than we can in the state of Michigan. So we received a grant from the Michigan Health Endowment Fund, and the plan was to have education, a suite of protocols, make this something that could be replicated, have data to support it, do some kind of a regulatory, whether it was an endorsement or a licensure, make it sustainable. So we were going to make it a thing in the state of Michigan. So I researched all the programs that we had in the state and looked at so many programs across the nation. And it was really obvious that this was not going to work, not the way that we thought it was, not going to fit. We could not take all of those things that everybody was doing and make them fit in a good package the way that we were doing them at the time. So we went back to the drawing board and we said, okay, first of all, we don't even have the same language. We're not speaking the same language. So we're going to define language, and then we're going to standardize a scope of practice and have education that matches that, and then protocols that reflect off from that, figure out how to replicate these programs easily, figure out how to get some good data, codify it, and then sustainability will come after that. So it was obvious right off the bat that we were going to run out of time. It was a 2-year grant. So we asked right off the bat, well, not right off the bat, near the end, when the time was appropriate, we knew we weren't going to be able to meet all of those objectives. So we asked for a second grant to finish up the work that we had not completed in the first round, and we got that grant. So first, let's start with language. Mobile integrated health versus community paramedicine. So mobile integrated health, that term, you could use that anywhere and it doesn't have any implications back to the EMS system. You don't see EMS in there, you don't see paramedic, you don't see EMT. So there's nothing wrong with that language. And from what I have observed from across the nation, these are kind of somewhat closed systems. So a mobile integrated health program usually has a champion that's like a hospital or a healthcare system or something like that. And the team has numerous players on it. EMS is just a tiny part of the mobile integrated health team. They may only do the 4th or the 5th visit. They may not even be a part of a mobile integrated health. Usually they are, but their position in that team is much smaller. Nurses, dietitians, you name it. So in community paramedicine, it is the EMS agency. That's it. That's who's doing it. They have lots of partners that they collaborate with, primary care physicians, local health departments, hospitals. They do some of the same overlapping work that a mobile integrated health, but there's also more work that they do that a mobile integrated health program might not. So then we came to, that's how we defined our language. Not everyone agrees with that, but it is working for us in the state of Michigan, and it doesn't grossly negate what you see across the country. So then we came with scope and role. So what we did is we got a group together of physicians, CPs, medics, everybody and anybody that we could think of. We looked at what everyone was doing in Michigan and across the nation, and we kind of made up a wish list of what would you like a CP to be able to do when they're going to follow up on your patients, or what's a problem in your community and what do you wish a CP could do? So that's really how we came up with our scope and role. Then we locked a whole bunch of ICs in a room for a whole day, and we took that scope and role and we sectioned it out and we made the curriculum objectives. Excuse me. Put those objectives in some semblance of order, and then we came up with a standardized minimum curriculum. Now this will be changing over time, so it's a lot of moving pieces, but this was a huge document and a huge piece to knock out. Then we looked at how we were going to replicate these programs. So now that we had a scope and a somewhat standard minimum education, we approved the courses, or we approved the programs that kind of met our standards. That's where people could get their education, and they have to go through a process of becoming a special study. And in Public Act 368, we can try new things in EMS to see if they're beneficial to the EMS system. But the programs that we had on the books when I came in, there obviously wasn't a dedicated coordinator. So how they got there and what they were doing was, there was no standardization, which was fine. Not everyone has to do the same thing, but I didn't even have the same information from everybody. Like I didn't have protocols that covered all of the same aspects of how to create a program. So we created a new special study guide. You can click on that link, and then an application guide that goes with it to tell them how to fill out that special study. In the future, once this is codified, it will be assimilated into the EMS system. It won't be a special study. Then we created the protocol suite. So instead of looking at the scope of practice or the minimum curriculum, the protocols reflect what you learn really well. So if you really want to know what a CP does, this is the best place to look. Now there's 3 sections. There's the protocol, or the program protocols. These I took the ones that were in the state of Michigan and the ones across the nation, I put them in a Michigan format. That's how we came up with these protocols. And what we're doing is taking them through the Quality Assurance Task Force, all of them, so that they are state protocols. So that doesn't mean you have to adopt them the way that they are. You can change them, but they do have to be reviewed again. The program protocols tell you the rules. They would be system protocols if this wasn't a special study. You know, what pieces you have to have in place, what protocols you absolutely have to have, what kind of physician director, that kind of stuff, what kind of policies you have to have in place, et cetera, et cetera. So we encourage a new program to adopt all of those. And then the procedure protocols are really flexible. I want you to think of that as a plug and play, the same with the treatment and population protocols. So you do not, so this is like fall risk reduction. Close your eyes from the scroll for a minute. Specimen collection. You don't have to adopt this protocol. That's what I mean by plug and play. If your program didn't want to do specimen collection, then don't adopt it. And if you did want to do it, you adopt it and you mark the ones that you're going to do: lab draw, urine, nasal swab, throat swab. So this is how we were able to have standardization with a whole lot of flexibility. Close your eyes again. I won't do that again. So data was our next piece. The EMS runs that we use, the EPCRs, they are not built for mobile integrated health or community paramedic care, not even close. So the data that we are going to be collecting needs to be meaningful, and it has to be related to the work that the CPs are doing. We're still working on definitions. So people who are familiar with epidemiology and collecting data out of like biospatial and things like that, it's really weird that not everyone defines a disease in the same way or an action in the same way. So that's one of the things that we're working on, matching our data to our scope, what we can actually do, and then figuring out how to insert that into the current runs. So there's actually 17 vendors in the state of Michigan, 17 different documentation, people who sell documentation tools in the state of Michigan. A lot of states, they make it be one and done. Everyone in the state has to use the same platform. That's not how it is here. So that's part of our challenge, is just if we had ESL say, yeah, we'll use this form, well, Stryker may not use that form. So we have a lot of work to do there. The regulatory part, the special study that I mentioned before, a special study is supposed to be for 3 years. After that, you either adopt the practice, you extend the special study if you don't have enough information, or you reject it and you end it. So we are past 3 years on quite a few programs, but we can't adopt it without the regulatory practice. So that's why we're headed in that direction. We discussed whether we should endorse it, certify, or license it. And honestly, they all have barriers, but licensure is probably, the easiest and the most sustainable long-term. It would also, when I am gone, I'm on a grant to make this project happen. When I am gone, if it were a licensure, it would be self-sustaining.
Hey, Chrissy,
Yeah.
just an FYI, we are seeing slide number 4. Are you seeing slide number 4 on your end?
No.
And it's frozen with the think bar on my end. So I don't know if maybe if you have a way to refresh or maybe just reload your slides.
So I'm going to do a stop share and a reshare, okay?
Yeah, let's try that.
It actually won't let me stop sharing. It's like I may not have control.
Is the internet just frozen? Is it maybe a little bit of a slow connectivity? Is it slow to respond or?
No.
Okay.
So I'm gonna stop video for a second. And now when I stop the video, can you see my mouse?
No, but I don't believe we normally can see your mouse anyway.
Okay. Could you maybe take away my ability to, I don't know, take away and then give it back to me?
Yeah, hang on a second. Because I turned over host to Victoria. She
Okay.
is
So I don't seem to have control because I can't even stop sharing if I wanted to.
Okay, I just took away your co-host ability and then
Oh.
gave it back.
Okay. All right.
there we go.
Now let's go back to share.
There's just bugs in the system.
It's
I'm
okay.
convinced of it. Thanks, Victoria.
Yes,
Yep, no
thank you.
problem. Thank you, everybody, for being patient with us as we work through this technical situation.
Yeah, thanks everyone. The regulars know there's usually something. It's usually a small bug or something we have to work through at some point.
All right, how's that? The protocol suite? Do you see that now?
That's what I see. Yeah, do you want to try
Okay.
a slide shift just to make sure they move?
Yeah.
Perfect. Looks good.
Okay. So
Thank you.
I'm not going to go back to all of those slides that I was discussing. Sorry that you didn't see those, but they will be there for your viewing later. We talked about the regulatory, and then the final piece is sustainability. Excuse me. The sustainability, we've talked to payers. Blue Cross Blue Shield, there have been quite a few payers. The thing is, they know that the services work. They are willing to, oops, my camera's off. They are willing to pay for the services. The problem is right now, how do they know how did they know without going through our office or going through a lot of paperwork, if a paramedic, an agency is out, they do something in the community and they bill Blue Cross Blue Shield and say, well, we're paramedics and we were in the community, please pay us $400 or whatever, the amount may be. They have no way of verifying that they have the right education and that they are working under community paramedic protocols, because it's not a licensure. There's no stamp, there's no endorsement, there's nothing. It's a special study. Part of the proof that people know that this works is ET3. They do not call this community paramedicine. It is not community paramedicine, but it is a shift in the mindset that we're realigning our incentives. We have been misaligned in EMS for a long time, only paid to transport patients to the emergency department. We are a transportation entity, period. We weren't part of the healthcare system, technically, even though we all see ourselves as healthcare providers. So that ET3, emergency treatment, triage, and transport, that is coming through Centers for Medicare and Medicaid is a huge deal. This is the world recognizing that EMS can do things other than transport to the hospital. I know a lot of people don't see them as being related, but they are very much related on principle. And then we have a lot of statewide partners from Michigan Department of Health and Human Services, from local health departments to substance use disorder, cardiac rehabs, diabetes, maternal infant. So they are seeing the value in how we can help them with their loss to follow-up patients or the patients that they just can't easily reach. All right, so right here, I'm going to pause here to see if you have any questions just on the structure part that I discussed. And now the next section, I'm going to talk about how community paramedicine can actually play into your agency and a little more application. But are there any questions on the structure part?
So the floor is open. Feel free to type your question into the chat box, or you can unmute yourself and just go ahead and chime in.
And if you don't have any questions, we'll do questions again at the end.
That sounds good.
So none right now?
I haven't seen any yet, unless someone's typing.
Okay, give me just a second.
Don't be shy, you guys. It's okay to unmute yourself. I believe there's also a raise hand function as well. So keeping my eyes open for that.
Okay. So I'll just go on.
Yeah,
All right, we're going to talk about the more practical application of a CP program and what that might look like for you guys. So first, we're going to talk about feelings because EMS people love to talk about their feelings. So I want to know, it's going to be a quick poll, how you feel about community paramedicine at this point. And again, not trackable, so please be honest. What's your current stance? Adamantly against it? Does not belong in EMS at all? Meh, on the fence, or good idea?
So poll is now up. You have 30 seconds to answer. Oh, interesting. Okay. All right. We have a few people left that haven't answered. So go ahead and chime in. Come back to your computer. You've got 10 seconds. 5, 4, 3, 2, 1. All right. Ending poll. Sharing results.
69% see the value, think it's a good idea, and 31 on the fence. I'm a little surprised that there isn't anyone that's adamantly against it, because quite honestly, there are people who are against this.
I've had a lot of conversations like that.
Yeah.
So yeah, I'm surprised too.
Yeah, I mean, it's a real thing, and that's okay. That's okay. So, okay, well, we'll take that down. Thank you, everyone. So, make sure I have control. Still moving, right? They flip the slide. Okay. So
Good.
this is not a new concept, community paramedicine, or whatever it is that you may have heard it called in other places. It's been around for a couple decades. Internationally, they have been using it for quite a while. And I have some countries listed there. They were kind of the leaders in it. In the US, it's been around since the early 2000s. Every single state, there's not a single state that reports zero activity. Now, what that activity is, that's the part that is a little bit unsure. So they've either had a conversation and determined it's not a possibility in their state, or they're not going to pursue it, or they are working it right now, trying to figure out how to make it happen, or they have active programs. I will say that even the states who have gone through some regulatory aspects of it, from who I've talked to, we are kind of the only state that is doing this top-down approach. So a lot of places, again, their agency medical director is the one who creates the education or tells them what their education is going to do, and it matches exactly what they're going to do. Whereas everyone's going to have this minimum level of education. That's what we're going to be able to test against for licensure. And then you'll become licensed, but you don't have to utilize all aspects. So imagine if you went to medic school and you only wanted to do trauma. You would learn it all, but you're only implementing the trauma part. Most of the programs that lasted for any period of time showed success, whatever it was their goal was, reducing ED utilization, reducing readmissions, whatever their line of service or their focus was. my point is that regardless of where you fall on the spectrum of either loving or hating community paramedicine, it's been around long enough and it's really taking hold, and we just have to decide what our level of willingness is to embrace it and how we're going to capture it. The ship has kind of sailed on whether or not it's going to be a thing. So here's what community paramedicine is not. It's not an answer for everything. It's not a resource that's available everywhere. It is not duplication or competition of established services. This is a big deal for community paramedicine. Mobile integrated health, sometimes when it's an agency from a hospital, their own team, it has the potential to compete with some services because it's its own entity, okay? We are public service, service above self, and we integrate into all different aspects of our communities. So we do not duplicate and we do not compete. We've got other things to do. And the other thing is CP is not a good idea for everyone. Being a good EMS provider does not make someone a good CP provider. The expectation is that an agency will only have one or two of these, maybe three. Some of the bigger agencies that run, like Huron Valley Ambulance, they run 2 CP trucks 24 hours a day, 7 days a week. They have about a dozen CPs. And that's what it takes to staff them, to staff the 2 trucks and let people have vacation time. But the majority of the time, people run CP services like Monday, Wednesday, and Friday. It's not the same as the EMS system, so they may only have 2 CPs. So what it is, it's a gap filler. It's a utilization of an untapped resource, which is us. It is more time consuming than an EMS call, and it actually may be a way for us to help ourselves. So remember when we talked about the resources that we have in the state of Michigan, the 800 agencies, 29,000 people, 87 counties. So I looked up some statistics. In 2015, nursing, and I'm not saying that we need to have these same numbers, but there were approximately 1,230 nurses per 100,000 people in the state of Michigan. Granted, they have a wider spectrum, nursing homes, hospitals, home healthcare agencies. So keep that in mind. But when I did the math, there is less than 1 paramedic per 100,000 people in the state of Michigan. I just thought that was pretty astounding. And that's RNs, not LPNs. So in the state of Michigan, of our 83 counties, 57 of them are rural. The purplish pinkish ones are considered metropolitan counties, which you can see like Oakland, Macomb, Livingston, Wayne, obviously. And then the metropolitan counties are, or the blue ones are metropolitan counties that have some rural tracts in them, census tracts. And when I was looking at the numbers, so in Wayne County, 1.8 million people, so that's 3,000 people per square mile, versus Keweenaw, which is way up there in the top of the Upper Peninsula. They have 2,000 people in the entire county. They have less people in that entire county than Wayne has per square mile. So my point with this is we have such a huge variety of EMS systems that this plays back into why we had to create a structure that is extremely flexible, and that because the needs in each county, MCA, are going to be completely different. So challenges that I don't have to tell you about that are EMS and rural focused are resources. In the rural areas, well, in EMS, but a lot in the rural areas, you have 2 people wearing 6 hats. So the mayor is the pediatrician, who is also the fire chief, who is also, you know, just you keep adding on. One of the arguments against CP is we can't staff our regular trucks. I get that. And we're going to get to how this might be able to help ourselves through that. Another challenge in EMS is access. So in the rural areas, there's no public transportation. That's what a lot of the other programs that I talked to around the nation said, well, we just, you know, we do this, that, triage, put them in an Uber. There aren't Ubers in Dickinson County, pretty sure of that. up in the middle of nowhere. Other things that are challenges, and this is not specific to rural, is where people do not have access to the appropriate healthcare, and ED is their all care. The weather in Michigan, that is a real thing that prohibits access, especially when we talk about elderly people who live far, far away from primary care physicians. And then time is one of our biggest challenges, especially in the rural areas. The time it takes to turn around a call. So in the agency that I used to work in, I could get a call, run it, drop my patient at the hospital, and be back in service. Sometimes, especially if I was working the city car, I could turn a call around in less than 30 minutes. When I worked in a far out county or one of our rural counties, that could take me out of service forever, because my response time to the call, pick up my patient, I get to the hospital, which is nowhere near my station, it's even farther away. And then by the time I get back into my service area, a call could take a few hours to turn around. And then not to mention system status management, sitting point. Sitting point for hours is horrible. So when Andrea's car takes a patient, and it's because we don't have any resources in the area, and she has a turnaround time of 4 hours on a call, I am sitting point for her for 4 hours on that call. So here's a big point that I want to make. This is what I imagine is always happening in the doctor's office. I'm sure it's not always this pretty, but hey, here's your medications, thanks. Any changes in your life? Yeah, I'm staying with my daughter now. We're going through some changes, but it's going to be fine. And what we see for her new environment, or this could even be her environment, not having to say that she's going to live with someone, this is the perspective that we see, that the primary care physicians or other members of the healthcare team don't see. I don't have to say anymore. Anybody who's been in EMS, this is sometimes what we see. And we know this is why things are not running smoothly. So maybe we can help ourselves while we help them, being the patients. I want you to think about for a second, and we're not going to do a poll or anything. I want you to think of one patient that was your frequent. So everyone has one, and even if you don't have one, your agency had one. Think of one call that you ran that was an unnecessary transport in your professional opinion. Think of a call that you transported to the ED just to have to turn around to transport back within hours. Now, not everybody may run a service like that where, once you transport, somebody else is going to bring them back. But this is a real issue for a lot of places. So think about that. And now we're going to ask why. This is what a CP does. We dig a little bit deeper. So think of the patient that was your frequent. Why were you always there? And let's just do this on face value. Frequent fall, intoxicated, lonely. I have had a patient that every time I heard the address, I knew I was going to get there. The patient was going to be on the floor. They were going to be naked. And there was going to be a bucket with feces in it. Every time I knew as soon as I had that address. And it was every single time. So that's why I was there. Well, what's the root cause? Well, the root cause was that was not managing his weight at all. He did not have a way to get in and out of his bathroom safely because there were no handrails. He did not have easy access to use the restroom. There were a lot of activities of daily living that he just couldn't do on his own. And his environment could have been made a lot more user-friendly. So that was the root cause. Think of one call that was unnecessary transport. Could you have treated it on scene? So there have been things where you were there, we're with our patient, and I think, man, if only I was able to, and it would be something little, like you just need some antibiotics. You just need some, something, you're not dying. If I could do this on scene, I would not have to come back here or go to the ED and pick you up. Could it wait till the next day? I mean, we don't refuse We don't tell people, you're just going to wait here and then leave them. A CP might be able to do a lot of things that we can't do in an EMS call to get them to a place where they can be treated the next day. And then the ones where we take the patient and then turn around. First course of antibiotics, the Foley cath that just needed flushed, things of that nature. Suture needed to be removed, something like that. Blood test run, lab draw. So let's look at the possibilities of these patients that you thought about. These are the procedures that we have. Point of care testing, the blood cultures, the lab draws, the urinalysis, nasal packing for the nosebleed. They're just going to get the nasal packing put in the ED, and they're going to have it taken out in about 24 hours. You can pack the nose as a CP. Suture removal, PICC access, vaccinations. The Foley catheter is a big one. That's a huge one. Flushing a feeding tube, or the peg fell out. Well, part of the procedure for feeding tubes is to put the replacement temporary tube in there. The reason that always goes to the ER is because you can't have a tube out of place for, I think once it hits 4 hours, it's between 4 and 24 hours, it actually starts to close up. So they have to put a temporary thing in there. They're not doing the long-term fix in the ED, but they don't have to go to the ED for that if you can have a CP do that fix. But that's not something an EMS crew is going to do either. It takes too much time to sit and do that. And then our treatment protocols. So the chronic diseases that you see, a lot of these are follow-up, post-discharge from either an emergency department or from inpatient. But these are the patients that everyone knows are going to be back in the ED within a couple of days, for numerous reasons. And a lot of times they are referred to a CP program from a care coordinator. But we also have some complaints like urinary complaints, gastrointestinal complaints, and non-traumatic nosebleed. There's also skin rashes, things of that nature that they may not be going to an urgent care for numerous reasons, but you can do almost a little bit of concierge medicine. We don't want to call it concierge medicine because we're not doing house calls. It's to fill a gap because they don't have other resources. So the real cost of doing business. This is the part we're gonna talk about, the elephant in the room here. So people say, until there's a sustainable model, this isn't worth it. We're not going to get compensated for it. Well, I want you to think for a minute about how much it costs you to run a call in the first place. Staff, wage, truck, and time. I challenge you to think different about this. Think about, you pull your truck out, there's a clock running, a money clock running, the minute you turn that rig on. The time that it takes you to pull out, all the staff that you have on that truck, go, do your call, maybe transport, maybe not, but regardless of how that scenario plays out, what if it's not billable? What if they don't have insurance? How much do you write off to charity care? I want you to start thinking about things like that. So if you were bringing down what you're writing off into charity care and you're only using one person instead of two people, this is where we start to reach, even though it's not compensation coming in, we are starting to reduce our losses. The other thing is compassion fatigue and burnout. It's a real thing. We're all humans, and it's not anything that I'm necessarily proud of, but you are not a medic. I was a medic for 20 years on the street. You're not a medic for 20 years and not have a patient that just makes you go, "Bleh, I'm here again." It happens to everyone. So that's the human being in all of us. And there's so many times that with these patients, I just thought, if we could just get it together for you, just get your poop in a group, then this would be better for everyone. But we don't do that as a part of EMS. Your counterparts would kill you if you spent an hour and a half and they were sit in point for you while you put up handrails and do things like that. That's not how the EMS system works. So that's the big thing about time for a CP, to be able to have time to do these things. So imagine if you could be empowered to fix those. And it is that population that does contribute to our compassion fatigue and our burnout. And that's just a fact. It's not a pretty fact, but it's a human fact. And the sitting point system status management. So when you say that my utilization was X for this 24-hour shift because I only ran 4 calls, I want to remind you that utilization versus me being asleep are 2 completely different things. You're right. I only ran 4 calls, but I was also only in my station for 2 hours because I was sitting point for someone else who was running calls that maybe didn't necessarily have to be calls. So all of these things come together and we can see how they can impact a system, especially a rural system. So is it worth it? Cons, staffing. We can't even staff our own trucks. That's true, but it could be staffing preservation too. Time. Nobody has time to do this. We can't dedicate enough time. Couple hours a day or a week with your top 5 might have a bigger impact on your system, especially if you can find 5 patients in your system that account for a huge percentage of your calls that you are not being, that are not billable. Start looking at it that way. Education. I recognize that education is a real struggle right now when it comes to community paramedicine, but I promise you we're working on that. And I'll talk about that in just a second. Resources, again, you need a person and you need a truck. If you are only doing what we used to call welfare checks, making sure they have their medications in the right place, connecting them with good resources, you don't need equipment for that. You need a person with patience and critical thinking skills, a community paramedic. You don't have to add on all that fun stuff that we talked about, the nasal packing and the UTI care. Oversight. Excuse me, oversight. Well, we've tried really hard to make it a canned thing for you so that the person who has oversight, yeah, it's a lot of work to get it up and running, but we're trying to make this as assimilated into EMS as the same oversight that you have for your EMTs or your paramedics. We don't want it to be a huge burden. So we're working on that. And then the compensation sustainability. You're right, we're not there yet, but we've been told that it's coming and we have to get our ducks in a row first. Nobody's gonna start paying us for a half-baked product, which we're working on. And we have a good solid plan. So, and again, bringing up the whole CMS ET3 thing, people are seeing the value in treating and not transporting patients to emergency departments. Another part on the pros is community engagement, especially if you're a municipality. Somebody mentioned it as this is votes in the bank because you are at Tuesday bingo, taking people's blood pressures, and everybody knows about your agency and all these wonderful things. And they came and they put up your handrail and they fixed your rug and, you know, got you Meals on Wheels. So that community engagement, whether you're a municipality or nonprofit or for-profit, but that community engagement is huge. Also, patient outcomes and patient quality of life. Those are things that are being tracked sporadically. They are in our plan to track. But when people do qualitative analysis and they look at how people feel about community paramedicine when they've had it, it's almost always raving reviews. And networking with other entities, people that we don't usually talk to, you don't know what you don't know. And as we've started to network with other MDHHS entities, there are so many things that I didn't even know were a problem. And they always say, well, we have this one little gap, you know, right here that we have trouble with these patients. And I just want to say, I see that little gap that you're talking about every day. Your gap is our every day, but we're not talking and communicating. very well. We are very siloed in healthcare. So right now, this is what it looks like for the status. We do have a few mobile integrated health programs. I did not put them on here. And we have had a couple programs that have closed, and one of them was mobile integrated health and one of them was community paramedicine. But the green dots that you see are the active programs that have been around for quite a while. This one up in Alcona County, that one just came on. We recognized right off the bat that we were not doing a good job in the rural area. We weren't, promoting it, but B, they didn't know. We didn't communicate well. So that was our huge push when we started this. And the purple ones are all programs that will be coming online probably right around January 1st. COVID wrecked everything. They should be up and running now, but we had to stall a bunch of clinicals and things like that. And then the red ones, the programs themselves are kind of in the conceptual phase, and they're all focused right there around Lansing because LCC is testing our minimum standard curriculum with the first community college class. So our second grant that we got, we're just finishing out with, we'll tweak our education to make sure that what people are doing and what they learned, that it all really fits together in a nice package. We'll watch our protocols, but the heavy lift is done on all of that. We can take that and send it to get a legislative liaison to see if we're going to codify this or make it a licensure. The documentation and data, our infrastructure build with the second grant is figuring out how to get good data and good documentation without making it a burden on the people who are doing the work. You shouldn't have to document in 42 places. Health information exchange, it's really hard for you to help people when you only have this much of the picture and communicate with the healthcare team. Sustainable education. So we've done a lot of investment there. And now we have 3 places in the state of Michigan. Munson Healthcare is testing the curriculum. HVA, excuse me, it's not COVID. Choked on my spit. Sustainable education, those 3 places are testing the curriculum right now. Once we look at how they did and what the providers thought once they're practicing, did we train them up appropriately? Then we will lay that out as this is the minimum, this is who can teach it, this is where you can take it, and then we'll start doling out that curriculum. And then the regulatory, I just spoke about that. We're ready. We just need to get a legislative liaison, and our office needs to start moving that through. And then sustainability, the last piece, you got to have all those other things together first.
Yeah, 1 minute. Oh, perfect. Okay.
And I don't mind if questions go over, that's fine.
Okay, great. I do have a question in the chat box for
Okay.
you. So this question reads, I don't fully understand the CP model. Is it similar to MIH? Is there a place in it for licensed EMS personnel who are not affiliated with an agency? For example, retired but still licensed or taking time away for family?
Okay, so that is a great question. The difference between the CP and the MIH model is an MIH, I'm going to use one that is I'm going to use 2 examples. And mobile integrated health model is there's an agency, or not an agency, an entity called Tandem 365. They originally got their patients through a healthcare plan. I think it was Priority Health. Priority Health picked their top 10% sickest patients and said, Tandem 365, let's figure out how to give them a year's worth of care through this subscription and keep them out of the ED and make them healthier. They have an entire team. They contract with Life EMS. Life EMS, their personnel, the trained ones that participate, do like the 4th visit or the 5th visit. So there's one example of mobile integrated health where an EMS agency is part of them. The second example of mobile integrated health is Henry Ford. I'm not sure what they call it. They use people who have similar training, but they are not through an agency. They are part of Henry Ford Health System. So they may have a medic license, but they're not working under their medic license. If they kill somebody, it has nothing to do with us, the state EMS office. So they're not called a medic. They're not recognized as part of any single agency, and they are not in an ambulance. We can call them MIH, happy helpers. It doesn't matter to me. Just don't call them a medic. So that's MIH. Community paramedicine, it has to be linked to an agency. Now, when you said, is there a place for someone to do this care outside of an agency? They actually have what they call community health workers. They don't have the same level of medical education as like a community paramedic, but they do a lot of the social aspects. So that would be one route. But talking about people who have been away or are retired, one of the thoughts was, how great would this be for preservation of staffing when you have people that don't want to do the lifting anymore? They don't want to work a 24-hour. They don't want that pace anymore. They want to sit down and figure out your medications and all of that. Wouldn't that be a great, I don't want to say retirement job, but a retirement job? No, they do have to be linked to an EMS agency. Absolutely. But again, community health worker would be the other thing I would look at if you are interested in that kind of work outside of an EMS agency.
Great answer. Thank you. So I don't have any other questions in the chat box. So the floor is open, guys. I realize it's 7:02. If you have to hop off, you can, but we're going to hang out and answer some more questions. So if you have any, feel free to unmic yourself, raise your hand. Here's another question. Sorry, I'm confused. Do you need to have a license to be a community paramedic?
Yes.
So,
yep. So
go ahead.
you have to have you have to be a licensed EMS provider working for a licensed EMS agency. And we put you into special study. So anybody who wants to be a community paramedic, that's not something that an individual does right now. This is something that an agency does. They want to do a community paramedicine program, and they pick a few people to educate to conduct that work.
Right. So like, for example, I would be a good example of this. So I have a paramedic license. I'm in the LCC class. I'm going to get my community paramedicine education, but at the end of this class, I'm not getting a license as of today.
As of today.
No licensure yet.
Right. So most of the people that are in that LCC class, because this is still in its infancy, we supported them through grants. And so what we did is we found 4 or 5 agencies that said, you know what, we want to do a community paramedicine grant. What is available through the state? And we were helping LCC to fill the class. So I know that like this township fire department has 1 or 2 people in there because I've already talked to them. Right now, this is very like you don't just do it. You come through our office. This is the pilot cases that we're doing. But once this becomes a licensure, you take your CP class, you get your CP license, and then you apply for a job someplace that has CP services.
Awesome. So I'm getting a comment in the chat box. I would like to learn more about the community health idea that you had mentioned. Can you send me information about that via email?
So Andrea, do you guys have any resources there do you work with the community health workers at all?
I don't, but we might have something in the office. I don't know. I'd have to ask the question.
This is Victoria. I can, some of our office workers actually work with community health workers, so
Okay.
we can put them in contact with some information.
Yep, perfect. Because that's a statewide system. It's MISHWA, the Michigan Community Health Worker Association. Yeah, they've got it together, and they're not in every single spot of the state, but yeah, that is a really good. That's where you need to connect. And community paramedics and community health workers have a really tight relationship. So they will often, the CPs will bring in or ask for a community health worker to fill a lot of gaps that are not within our purview.
All right, I just emailed that respondent and we'll connect. I'll get it connected because now that I think about it, it's probably Sarah or someone in our office because we do have a lot of public health folks. So we've got a few things in the chat box here. I am wowed at the progress Michigan has made in this area. My question is, have you heard if Wisconsin is coming through as you have? I'm located in Wisconsin. Do you have any contacts there?
I do have some contacts in Wisconsin, but I gotta look. We're all in different stages. And again, Michigan is really the only one because of our wacky structure that our hand is kind of forced to do the model as I described it, you know, with the minimum curricular education and the plug and play model, plug and play protocols and things like that. I will look to see who I have in my contacts for Wisconsin, and I can forward those to the person.
Okay, excellent. Yeah, there's a lot of comments in here. I'm just kind of going through them.
I've had a lot, my biggest contacts have been, or my tightest contacts have been, I have like the mom and infant program that out of Indiana, Crawfordsville, Indiana. I call them friends, but we're acquaintances for all of these. A guy out of Indianapolis who does the Shalom Project. The state office out of South Carolina, I've worked with them quite a bit. And North Carolina, they have a substance use disorder. I've got a couple friends there that we've been talking, and they've helped us develop our SUD protocol, and they're doing medication-assisted therapy. So we're copying them. We copy each other a lot whenever we can. And these connections that we've made, there was supposed to be a national conference in August that we were supposed to speak at and present the Michigan model to, you know, but it got canceled. They didn't even do it virtual, so.
This is Victoria again. We have a contact in the state office of Wisconsin's Office of Rural Health. We might be able to put them in contact and see if they could have some information about community paramedicine program that's happening there. We could put you in contact with them as well, Kristine, if that would be helpful.
Yeah, if you want to give that one directly to the person, and then my contact information is here. If the rural health office does not have a resource for you for the community paramedicine, then reach back out to me and I'll see who I can connect you with.
Yeah, for sure. And you can pass some of that on to me as well, Victoria, and we can work together. But very, very good point on that. That's a very good point. We have a lot of contacts there. So, and keep in mind, guys, you have these slides in your email. So you can go ahead and go into your email and take care of the contact. And also in your email is the quiz, which I'm going to get to here in just a second. But before we get too behind, let me just read this comment. So I'm going to take out the agency name because we need to be very non-biased about opinions. But it says, I work for ABC Ambulance. So this is a large organization. And our CP program has been very beneficial for many reasons you listed. I have used our CP so many times and have been able to prevent our patient from going to the ER, catching health conditions early in patients that normally would have waited till much later, eliminating trips to doctor's offices, etc. It's truly a great program. So more of a comment than a question there.
And if that's a Michigan program,
yeah,
you're right. We do have to be, but I know exactly who you are because every single one of you is a special study. So, and I know which ones are the big ones and which ones are doing the most work. So you're right. And you are doing a great job over there somewhere around here.
Yeah, I don't see any other questions. Does anybody else have any burning questions they would like to unmic themselves and tune in? I am actually going to hop out of the screen for a minute. Victoria, you are clear to stop streaming to Facebook. Oh, she was right on that. What was your finger over the button?
Yeah.
I do have one question. Has anybody talked about immunizations, like with the COVID vaccines and stuff?
Yep.
That's one thing nationwide is huge right now. And because we have so much contact with people.
So we have a vaccination protocol, and you just mark whichever vaccinations your MCA is going to do. And I added COVID when available on that. But in Michigan, we actually are working with the immunization office that the local health departments are going to start using EMS. Well, maybe I'm saying this a little prematurely because now that I'm thinking about it, the call that I heard it on was no, Dr. Fields talked about it on the state call today or yesterday. So I'm okay.
He did.
Okay. They're going to try to utilize EMS for all of these things because we have so many peds too that have gotten behind on their vaccinations. But yes, right there with you, Chris. Like,
Good, thanks.
So the other thing I want to quickly mention, I'm trying to grab that quiz link because I know a lot of you love it when I drop it in the chat box. So I'm working on that right now. I'm going to stop recording.